to use Tony as the launching pad now and kind of light the rocket a little bit. What I thought we would do is hear from 6 of the original surgeon investigators in 6 different artificial discs. You have 3 of them here in person. We have 3 of them virtually. We're going to do it in chronological order. For Jim Yue is occupied, and we're going to try to let him go first, but he's too occupied. He is just going to do this on audio tape, so we'll put it back in chronological order. So, Rick, if you don't mind, Rick Geyer is going to talk about the Link disc, which was the precursor company for the Charite and brought the Charite into the country, and then Scott will pick up the Charite story part 2.
Thank you, Jack. First of all, I want to thank Jens and the whole Seattle Science Foundation team. You are terrific, and what an amazing facility. This is my first time in person, so I am really happy to be here, and my heart goes out to everybody, and also to Jens for having the foresight and having the leadership of making this really go. And also, I want to thank Tony and his brothers, because really without them, we wouldn't have disc replacement. We wouldn't have implanted so many of these artificial discs in our patients. And it is a technology that is really amazing for our patients. And Tony, I thought your talk was terrific, the way you put everything together in perspective. So what I'd like to do is just spend the next few minutes talking about the Link artificial disc and how at TBI we started to think about this. So my disclosures. So we used to sit down at our Friday morning conferences, much like you have a conference room here. And in the mid to late 90s, I noticed that, we were operating on fusion patients and reoperating. And, although we didn't have the internal fixation that you see on the screen there, we nonetheless had these failures of fusions. And I originally, before going into spine, I was going to be a total hip maven. And I was going to go and work with Charlie. I'm that old, but I would have been his last fellow. But in any case, I questioned, what about a lumbar disc replacement? Because we don't do hip fusions anymore. We just do artificial hip joints. Again, going back to what Tony was talking about. So there were many attempts, but we heard about a German disc from East Berlin called the SB Charite. And that was bought by Link that Tony had mentioned. So early in 1990, we sent one of our fellow graduates who spent a year and a half with us before starting to work with us over to Germany. His name was Alexis Shelikov, an absolutely brilliant fellow. Unfortunately, had an untimely death at the age of 50. But in any case, he went over to Germany with our research team to see if this was really the real deal. And they came back and they said, yes, it was. And it wasn't used clinically. They looked at the x-rays, looked at the outcomes. So we started communicating with the inventing surgeon and the manufacturer. So here was the history. So in 1982, they started the development. Kurt Schaunack was the chief of the spine service at the Charite Hospital in Berlin. Karen Buettner-Johns was just a resident. And then, of course, the Charite came from the name of the hospital. So Karen was an amazing gal. She was raised in East Berlin. This is before the wall came down. She was an Olympic champion. And as an orthopedic resident, she helped develop and write her thesis on disc replacement, which was really incredible. You think about the residents out here, any of you are going to come up with an idea like this. So we invited her to come over to TBI in 1991, and don't make fun of the hair that I had back then, but... Oh, cool. And then we translated her thesis into English through our research foundation. We had a gal that was a linguist and somehow translated it for her, and then we published it. So this is just a little bit of the first Charite. It looked like Coke bottle caps, how it stayed in there, amazing. This was the Charite 1, and then they had a 2 version with little wings. Again, it was just a core that was sitting in between 2 metal cups, and then finally the 3. So, but before the FDA in 2000, our biomechanical lab at our research foundation actually completed the required FDA testing in the late 1990s before the FDA would approve it. And we had several Instron machines, and we were quite proud of our lab. And it was kind of amazing that we did it in a private lab. There's a lot of discussion among Hochschuler, myself, Blumenthal, McAfee about who would do the first implant. But Dr. Blumenthal did a lot of whining as usual, and the rest was history. So he did the first, McAfee the second, and I did the third. But you get no awards for second and third. So with that, I'm going to turn it over to Scott and let him pick up the story.
I wasn't expecting the whining comment. All right, so do we just go on? Or do I have to start a new presentation? Hello?
I think it's a new presentation.
Okay, I don't know how to use Mac, so if you can just put my presentation up.
You know what? While we're waiting, I visited Karen in Berlin when we had an ISAS meeting there, and I said to her, Karen, can you show me your medals from the Olympics? So she crawls up in the closet behind her, and she digs them out. And I said, why don't you have these on display? I'd have them in a display box. But she was just a very modest gal.
All right, here we go. This actually will dovetail really nicely to both Tony's talk and Rick's talk. So this is Brian Cameron, who Tony had alluded to before, who was made the president of Link Spine USA, whatever, where Annie Greenberg was Link Ortho. So this is late 1999 when we went over to Europe for the first time to kind of look at this technology and get trained in it. And the first doctor we visited was in the Netherlands, and we wanted to get a coffee in the morning, so we saw a skunk bar and we thought that was a coffee shop, when in fact, a little naive at the time. But at any rate, that is Dr. Willem Ziegers, who, the late Dr. Willem Ziegers, who is one of the pioneers of the Charite. That's Paul McAfee and me, many years younger. So we're kind of looking at this stuff, and this is the surgery that we did. He let us scrub in, let us do part of the cases so that we could kind of get comfortable with it. He was a very interesting kind of dude for those of you that have gotten to meet him. Next, we visited a doctor in a city near Paris called Arras, which I hadn't heard the name of that city until the news yesterday, because some nurse got stabbed there. I mean, because of all the stuff going on in the world. But anyway, this is Dr. Terry David, and this was the second stop that we made. And Dr. David had this really cool instrument that was not part of the Charite set that allowed you to take a collapsed disc space and distract it in a parallel fashion. And McAfee and I told Brian, I said, we need this, and in fact, it should be in all the sets, and now it's in every ProDisc set as well, the David spreader. And it's been misspelled many times. It's actually spelled David, but Terry David is credited with that spreader that is now used and copied all over the world, and we use it on every anterior lumbar fusion as well. It's a very, very powerful tool. All right, then we moved on to Hamburg, Germany, the headquarters of Link, and that is Helmut Link, who Tony knows well. And it's interesting because when he didn't want to sell his baby, the baby grew up, and a few years later, the groups to purchase the Charite, which eventually was DePuy, but also at the table was Medtronic. And his line to both of them is, why should I let you marry my daughter? And interestingly enough, and I didn't know this story about ProDisc, Medtronic made the higher offer also, and he took DePuy's. So obviously, there was some bad juju going on there with Medtronic, and since they got burned twice, they really did effectively cripple the reimbursement for this. I thought Helmut Link was a very interesting guy. You know, oh, I lost my slide. Okay, I had a great slide of Dr. Evil from Austin Powers, because he kind of had that look, and but I guess I lost it. At any rate, this is us kind of looking at the first set. This is his kind of number one or number two man. Interestingly enough. This was the case number one that we implanted in March 2000, and it really wasn't whining. It was merit. It was a meritocracy. It was earned, not given. But anyway, and this is him, I think, at about 9 years, and I actually he's kind of stopped coming back for follow-up because he'd be interested to have a 24-year follow-up if we do it next March. Let's see what else I got. That prosthesis, interestingly enough, had no porous coating. So the whole IDE study and a lot of those original European patients that Karen didn't have a coating, and then right after FDA approval, they allowed the company to add a bony ingrowth. So some of the original patients have, I don't even know what's holding them in. I mean, it's incredible. But having said that, Rick just referred to the ISAS meeting or the SAS meeting in Berlin, which was the 20-year history of the Charite, or 25 years. And this was an interesting panel because it had the pioneers of Charite in like every continent. Terry David's on the left, Louis Nell Sr., who kind of pioneered it in South Africa, Matt Scott Young in Australia. And the interesting thing was, do you remember that picture that Rick showed of Karen's first patient playing tennis after it? That's him at that meeting 25 years after his implantation, kind of giving his story about being patient number one, which I thought was just like a fascinating event. So I think that's all I have. Yep, that's it. Thanks.
Thank you, Scott. Anybody have any questions for Rick or Scott? Well, Ben, I need some help to fund my talk as well.
You know, Jack, I'll say one thing. When I think back of when we first started putting the Charite in, if you think about the technology we have today, and Scott had mentioned that there was no coating, it was smooth, it was just held in by spikes and compression. And today, if you would mention that, I'm thinking we were out of our mind to put that in and thinking that it was going to stay there. But it was only halfway through the study when they put the porous coating on. But yet we still see those patients come back, and amazingly, even though I think one of the fellows or residents had asked about unconstrained, it was a totally wobbly implant, and so it was not a good implant for the long term, but if you put it in perfectly with somebody without any deformity, they did great.
So again, I want to congratulate you and the Viscogliosi brothers for having changed medicine. Again, we put so much emphasis on MIS, robotics, whatever. Again, all these various new things. This is a true game changer that you've done, and this has not been recognized enough, I think. My question to you is, the implantation of the first disc replacement happened on the heels of the pedicle screw litigation, an extremely hostile, very entrepreneurial, if you want to be pro-plaintiff, but very devastating, potentially, litigation. Were you worried about the exposure in terms of trying to put something completely new into patients on the heels of something that actually was very well proven at this point in time when this litigation happened?
I was excited because, if you think about it, it's just like Tony's chart. The fusion was a good solution that we had at the time. It is not a natural solution. The natural solution, as he said, is replace and now regenerate. So we weren't thinking about that, although we did get lots of darts thrown at us with people saying, oh, you're going to kill the patients when they slip out and when you have to revise them. That never happened. And even after us doing them 23 and a half years, and Tony mentioned a 1% revision rate, we're less than 1% when you take out a Jack's learning curve, Scott's, and my learning curve. It's like 0.8% revision rate. So we never saw all those bad things, but we just believed in it, and the three of us just kept plugging along, and it still is a great operation. It's just, it hasn't taken off the way the cervical has. Cervical is a no-brainer and probably the new gold standard.
Yeah, and Jens, I think we had some comfort that it was being done as an FDA study, that it was being done scientifically, it was being done, under the protection of the umbrella of the federal agency. And that, my noon talk, I'll talk a little bit about how that changed my perspective of the FDA, who before that I saw as obstructionist, being in the way because our European colleagues could, bring something out of the garage and start implanting it, and we were, handcuffed. But, I grudgingly came to realize that it's not necessarily the best thing. So I think the protection of an FDA umbrella made all of us feel better.
And if I may ask, Tony, as a segue towards your very important lectures, you mentioned that the Americans were good at marketing. But I think that what happened here, which makes this so different, and this is just pursuant to what Jack said, there was actually real research done. Nobody had done this. Was this part of your venture to basically spawn and mandate that this be accompanied by quality research?
Yes. Absolutely. So the brothers understood, because of the pedicle screw litigation and the failure of the evidence not to have been presented in a PMA format, that if we followed the PMA rules and the IDE rules, this would evolve as a superior technology. It was a clear business strategy. It also was a competitive strategy, because none of the companies in the orthopedic industry wanted to invest the R dollars. They would invest D dollars in R&D, but not the R dollars of research. We said, if we take the risk of demonstrating that clinically, does it work or not? Is it safe? Is it better? The outcome will create much more value. And voila, that's exactly what happened.
One question I have is, at the time I was very active in an organization called AO, and we had this hope that as this new technology comes into the country, that we can actually create a spine registry for arthroplasty. Was that something that you had considered? And I'm sure you did, obviously. Why did this not happen?
So the answer is absolutely yes. And it was a cost issue with the buyer not to continue the registry that we had begun.
Thank you.
Thank you, Jens. So I'm going to continue the timeline and tell you my vignettes about the inside story of the beginning of ProDisc from my perspective. So this is the intraoperative picture of the first ProDisc being implanted in the U.S., and that was on October 3rd of 2001. So if you just kind of dial back a little bit, it was 3 weeks after 9/11. Which obviously is a little sobering considering what's happening in the world now. But at the time, the airports were very empty. It was a very unusual time to be starting a multi-center study across the United States, where teams of people and surgeons and industry people and were kind of traveling around. But again, the airports were so quiet. At one point, I looked down a long hallway and said, you could throw a bowling ball down and there'd be no people in the way. So interesting times, but that's how far back this first case went. Tony has set the stage a little bit in some comments from Rick and Scott. It was a very competitive economic situation in 2001. Lumbar arthroplasty obviously was being looked upon by the investment industry and maybe also the physician industry as a potential blockbuster technology. This, we were all saying, this is going to change the way we take care of patients. And of course, the naysayers were saying, you guys are crazy. As Rick said, they were throwing darts. Charite had launched its PMA in 2000, as Scott showed you, and ProDisc followed in 2001 with the first single-level implantation, and then in January of 2002 with the first two-level implantation. So things were rolling. All the sites were enrolling, people were coming in. Maverick and Flexicor started their IDEs soon after that, and we'll hear from John Peloza after me to talk about the Maverick study. And sessions at spine meetings were interesting, to say the least. There were symposia about this new technology. There was antagonism, coming from the floor where surgeons were very skeptical about it and accusatory. And interestingly, the surgeon champions, 3 of them here and the other guys that you'll hear from, were friends, but it was rough. It was not friendly, and not only was each surgeon trying to espouse the advantages of their own disc, but there was always a little dig at keels and teeth and and fixed and moving, and there was a whole, without a lot of scientific evidence and certainly no clinical evidence really at that point. So they made the sessions much more interesting than usual. It wasn't just people getting up and giving a talk. The background, as Mr. Viscoliosi shared with us before, this is Terry Marnay. Terry is a classic Parisian-trained French deformity surgeon and an inventor, and I call him a Renaissance man. He's a pianist and plays guitar and paints, and so he's got a lot going on. But he actually developed the idea for the ProDisc, implanted it, as Tony said, into 64 of his patients from March of 1990 to February of 1993. And then he did what very few of us, I think, would do in that environment. He stopped. He stopped putting his baby into patients because he had the academic restraint to say, now I've got to see how they do for a while before I continue doing this, rather than let's put in as many as we can as fast as we can, which is sort of, maybe that's an American mentality. But so these patients were in the oven. You know, the cake was rising when Tony Viscogliosi and his brothers decided we need to find these patients and see whether there's some clinical merit, or is this a path we should not be following? You know, again, showing some academic presage. You know, they were kind of looking ahead. So of the 64 patients, 3 had died of unrelated causes. They had been put in 10 years ago in patients in their 70s. But of the 61 surviving patients, they found 58. They brought them all in. They interviewed those patients. They had them fill out questionnaires. All the patients were x-rayed. They brought an independent spine surgeon from the United States over to look at the films and adjudicate whether they indeed were showing what they were claiming to show. So of this 58 of 61 patients, that's 95% follow-up at 7 to 11 years. And none of the implants had failed. None of them had been removed. None were subsiding. There was no migration. The patients were significantly satisfied, and there were no device-related safety issues. So that's very strong historical data, and as a result of that, they got one of the earliest approvals for a pre-market approval study through the FDA when they brought it ultimately to the US, and I'll talk a little bit about that at my noon FDA study. So here's my first little vignette. It's titled ProDisc and the Frenchman versus Dogs. So in early 2000, Frank McGee, who, like our friend Ron Christensen, is the Director of Medical Education at Sentinel, are both doctors of veterinary medicine. Frank so has very strong scientific and basic science background, but also he's very strategically gifted and can kind of see the way around problems as they come up. So he presented to the FDA and he showed them this long-term follow-up on the 58 French patients. And the FDA's initial response is, this is terrific. Can you show us some animal data? Or if not, you have to go back and get it. So there was a pregnant pause in the room, and Frank's response is, I've just shown you excellent long-term clinical data on the large European primate. He said, and he said this to the FDA people, he said, do you really want me to go back and tell the French that we now have to test it on dogs? And there was another silence in the room, just a long pause as the FDA people realized he's right. And after a quick chagrined huddle, they rapidly approved the PMA study. So the lesson to all of us is, usually when we're dealing with governmental agencies, when they tell you something, you say, okay. But, when they're wrong, it's also okay to push back a little, or at least it was in 2000. Hopefully you can still get away with it. But just a great story. And the outcome was a very quick PMA. So it brought a smile to Tony's face. And the second little vignette that I'll share with you is, I titled it ProDisc and the Atkins Diet. Because as the guys said, TBI was already an enrolling site for Charite when the Synthes, not the Synthes team, but the ProDisc team in Europe was confronted with Steve Hochschuler, one of our senior partners, who said, I want TBI also to be a site to enroll ProDisc. And Steve Hochschuler can be very, very persuasive. He kept pushing, but because of this extremely competitive anticipated environment between Charite and ProDisc, the ProDisc guys said to him, there's no chance that we're going to do this at the same institution. You're crazy. But Dr. Hochschuler kept pushing, and over lots of drinks late at night, he got the ProDisc team to minimally agree to come visit Texas back and go out to dinner with some of the proposed surgeons, which happened. So over steaks and no carbs at the time, Frank McGee and I looked across the table at each other and realized we were both on strict Atkins diets at the time. And we started talking about that, and we have very similar backgrounds, both from New York and both grew up kind of in a middle-class background. And we hit it off. We liked each other, so that at the end of that dinner, rather than shaking hands and saying goodbye, we worked out a way to be able to run both studies in the same institution, kind of with a wall, where we promised that we wouldn't cheat, we wouldn't look at the other guy's problems, we wouldn't publicize any issues that came up. And it worked out. It was the first and I think the only time that two really large and scrutinized studies are being run at the same institution. But it paid off wonderfully, because TBI was the #1 enrolling site for both studies, side by side, running even concurrently at the same time. TBI surgeons were the authors for the seminal pivotal papers for Charite and for ProDisc single level. We followed these cohorts of patients for 5 years, and Rick Geyer published the 5-year Charite data. Rick Delamarter and I did the 5-year ProDisc data. And Scott was a co-author even on the ActivL paper, which used ProDisc and Charite as its controls, because at the time it started its IDE study, both ProDisc and Charite were FDA approved, so they didn't have to run their study against Fusion, they could run it against. So we got free shots at long-term data on ProDisc and Charite from completely different sites, surgeons, and certainly different patient bases. So a lot of good came out of that. We've walked the walk at Texas Back. This is our number of lumbar devices implanted per year through second quarter of 23. And you can see the early rise was during the enrollment period for artificial discs. And then the drop-off is post-approval because of reimbursement issues that developed that Mr. Viscogliosi alluded to. And there was a long sag in there where it was very difficult to get this reimbursed. Despite that, we hustled. We were trying hard, still made some good enrollment. But then you see after 2015-16, when Esculap brought ActivL to market, they made a very strong push to get reimbursement and get medical policy approvals changed. And that has resulted in a significant increase in the number of patients we're able to deliver this technology to. And you'll hear later from Kim Norton, who's the reimbursement specialist, who I think is one of the key people in turning that reimbursement sag into growth. So we lived through all that. And at TBI, we've got a lot of surgeons who put in an occasional disc, but you can see that the majority of the cases that have been done over the last 23 years have been done by the three of us. We drank the Kool-Aid early. We took a little bit of a risk because nobody knew in 2000 and 2001 whether this would really turn out to be a good thing. But we took the risk because, again, we had some safety in the fact that it was done in a scientific way, lots of layers of oversight that I'll talk about in my noon talk. And we lucked out. We were in the right place at the right time, the right technology, and we've been able to help a lot of patients over a lot of years, despite the fact that people still throw darts at some of this, but that's a different story. So it's been a great experience. Terry Marnay, just a brilliant man, and his foresight on the surgeon side, and Tony Viscogliosi's on the investor side and the business side, just really brought this in and let us do things like this. This is a young guy. A young guy with 3-level disease who was told by multiple surgeons to have a 3-level fusion. He's in his 30s, he's in his mid to late 30s, and a 3-level fusion in someone like that means that not far down the rest of their life, they're going to be a back cripple, they're going to have trouble. So, we have technology that we know will do better for him than that, and we can do that because of people like this. And just to shout out my combat foxhole buddy, Mickey Morgan, who's my access surgeon and has done all these cases with me, retired 2 weeks ago. Mickey and I did 3 artificial lumbar discs. He took off his gloves and he retired. He hung them up. So there are people like that also who have made our lives wonderful. We're lucky to have good access surgeons at Texas Back, and there are good access surgeons around the country who help us do it. So retire and he's not rested. He's not dead. This is from 2005. So that's the ProDisc story. Thanks. I saw Dr. Peloza online before. Ben, are you going to patch him in? John's going to talk to us about the Maverick study.
There he
Yes,
is.
I'm
Hi,
ready.
John.
Oh, good. Thanks, John. It's all yours.
Okay, this is a talk about the next disc, the Maverick disc, Top Gun, as you will, and its development. I was going to talk a little bit more about the engineering decisions that were made in the development or design, because there's always, when you're talking about engineering something, there's always there's always competing interests on a design, and you make your best guess as what's going to be the best. Okay, Corey, I don't see my arrow here.
Okay, just
There
got
it is.
it?
Yeah.
All right.
Okay, so the kinematics of the spine, pure rotation is the principal motion in the functional spine unit. And the translation is not as significant. And there's a pseudo translation, but it's really a rotation around this center of rotation that's in the posterior part of the segment. It's really not one point. It moves a little bit too. So this is the fundamental thinking or the fact in making and design decisions. Okay, Corey, I keep losing my arrow here. There it is.
You just got to move the mouse. You see it?
Yeah, I got it. Okay, so the specific design features of the Medtronic is it was a metal-on-metal disc. At the time, and this was before the metal-on-metal problems started with the hips, but and I'll tell you why I went to metal. It also had the posterior center of rotation. It's a major mechanical kinematic feature. It was a two-piece design rather than three. And because it was a two-piece design with a keel cut and such, the inner space did not need to be distracted much to put it in. So it was a very streamlined technique. Okay. So on design features, there's different materials you can use in a disc, polymers, metals, ceramics, combinations of it. And in terms of metals, you have titanium, cobalt, chrome, stainless steel, and then other constructs. So there's a lot of experience in the hip and knee arthroplasty space in terms of what works. So cobalt chrome has really good wear features. The thing that is important is the harder a material is, the less chance it's going to break down, wear, and then create particles. So in initial polys, they were soft, and it was the way they were sterilized, and they oxidized. But in a polymetal construct, the poly is the thing that fails because it's softer and then it sheds particles that cause a tissue reaction. In terms of ceramics are very strong, but they're brittle. So they can have a catastrophic failure. You know, you drop a ceramic plate on a floor and it'll just crack everywhere. So that happened in total hips with the ceramic head, and that was a catastrophic failure. And once it happened, it shed particles and ceramic shards all over the soft tissues that when you did the revision, you couldn't see them. And that would create an abrasive problem with the next revision material, no matter what you use. So we decided at that time not to go with the ceramic, not to go with the poly, and to go with the metal on metal. Now, things have improved quite a bit. Polyethylene now is sterilized in sterile conditions, gas plasma and such. It also has high density polymer, and it's cross-linked. So it's very, very hard and resistant to wear now. Also, the ceramics have been engineered to be not so fragile, so brittle, and they're very resistant to wear. So the things you worry about in materials is it biocompatible, it's resistant to corrosion, has high tensile strength, and all those things are there now. But at the time, this was in the early 2000s, this was being designed, went with metal on metal. Now, we talked about constrained versus unconstrained. So we felt that the constraint would be better with a fixed spherical ball and socket. And in the posterior part of the motion segment, to more mimic the center of rotation. So the reason we wanted to put it there is to prevent translation and to hopefully unload the facet joints to decrease the force on the facet joints and then eventual degradation of the joint. Because the segment is a 3-joint complex and we're only replacing one of them, we wanted to preserve the facet joints as much as possible. Then there was the fixation to the bone, and so we felt that from the disc, from the hip and knee arthroplasty experience, coated surfaces, hydroxyapatite, or some bony ingrowth was superior to smooth, and then felt that the keel would give it more immediate fixation rather than teeth or rails. So those were the design features and the decisions made to press on with the design. Okay. Let's see. Can we advance? There we go. Okay, so the results of the FDA ID study and the 2-year outcome, we published that the study started in 2003, fully enrolled by 2005, and this was published in 2011. So the inclusion and exclusion criteria is very similar to all the other studies, and the primary endpoints, secondary endpoints were all very similar as well. So the Maverick was the investigational device, and the control fusion was the LT cage with infuse, which was a very advanced control at the time, and it was a tough control to beat. Now, this was designed as a non-inferiority study, which made sense for industry. So anyway, the Osseous Disability Index, the for the Maverick was 53, for the Fusion was 54. So these groups were very well matched. And you can see at 2 years, there was a significant improvement in the ODI. Anything less than 20 is essentially almost a normal function. So you can see that both the Maverick and the control, the Fusion, did pretty well. Also during this time, the sports study was going on, the spine patient outcome research trial. And we felt at the time that those investigators were somewhat biased against surgery, and they were literally trying to prove that surgery didn't work. So one of the things these studies showed in a randomized prospective manner that fusion actually works pretty well too, but the disc replacement, and particularly this implant, was better. So you can see the VAS scores for pain, for low back pain and leg, were also significantly improved. This was on a 100 rather than a 10-point scale, so 71.7 down to 18 for the low back, and then also a significant improvement for fusion. Most of these patients did not have significant leg pain. It was mainly a mechanical low back pain population. In the SF36, you see the pain, the physical component score and the mental component score. These people were well selected. They were pretty reasonable, not psychologically pain patient type people. So their scores also improved both for the pain and the mental part. Patient satisfaction was very good in both groups, but particularly good in the Maverick. And one thing that was statistically significant was the return to work for the Maverick was 75 days, 96 days for the Fusion. The success rate, and you realize there's 5 questions you have to answer for success on the FDA criteria. And most of the time that degrades the overall success because there's always some other thing that happens, another intervention. And in the case of both groups, particularly in the Maverick and one of the investigators in the first 5 cases had to go back and do laminectomies or foraminotomies for soft tissue or bone that was pushed back into the foramen and then caused some problems. But anyway, in terms of in terms of a non-inferiority, it surely met that criteria. However, when the stats were evaluated, it turned out it was statistically superior to a very modern fusion technique control. So we thought that was important, and we were really happy with the results of this study. Hang on a minute, let's see. Can you just advance that slide? I'm not Corey? There it is. Okay, got it. Okay, so then we followed up on the 5-year study. We published that in a journal of neurosurgery. Now the follow-up fell off a little bit, and it fell off a little bit more in the fusion group. But again, the ODI improvement was sustained. In fact, it was actually improved in both groups. And the VAS scores for back and leg pain also was sustained over the 5 years, as was the SF-36 physical component, mental component scores. Now, the people were working preoperatively, 61% in the Mavericks, and they were up to 75 at 5 years still working, and 55% in the control and 72% at 5 years. So in terms of the secondary endpoints, I think it was a really successful intervention. Patient satisfaction for both groups was still very high. And again, overall success rates were good. Now, the tenured outcome data, and this is from Europe, it's from Marco Breda-Bruno and Charles Leck, and they didn't have a randomized control group. It's just their prospective series. And again, their results were also very good for the VAS scores and ODIs. You can see pre-op scores versus the 2-year and then the 10-year. All the good results on the osseoustry as well as this pain scores were sustained at 10 years, as were the SF-36 scores. Now, they also looked at Jean-Charles being involved. He also did EOS imaging on everybody, and he looked at pelvic parameters, and the disc replacements maintained the segmental lordosis as well as the lumbar lordosis pelvic incidence ratio and pelvic tilt. So in terms of what a lot of people think on adjacent level disease, that it's important to maintain segmental lordosis at each segment as well as the overall balance of the spine. And so he showed in their 10-year follow-up that that was true for the disc replacement. He also looked at the range of motion. Now, most of their cases were done at L5S1, to a lesser extent 4-5, and only a few at 3-4. But the range of motions was maintained at 2 years and pretty much the same at their 10-year follow-up for each level and each index disc. The thing that really was apparent was that the failures were because of the facet joint degradation at the index level. So they had about a 21.6% incidence of that based on their imaging, and 12% of the patients went through a radiofrequency ablation, and 4% had a posterior fusion for the facet problem. Now, the other thing that came out of this study is that there wasn't really any clinically significant adjacent level disease at either the disc or the facet joint. So they looked at MRIs using Fujiwara's criteria, and a disc, about 10% of them went from a type 1 to a type 2, and another 20% from a type 2 to type 3, with no significant facet degeneration. Now, again, this is the adjacent level to the disc replacement, and they had no correlation with clinical outcome. So it again, I think at least some evidence that the disc replacement does spare the next level above. And I think that's really important. So, okay. So in conclusion, the Maverick was a very successful disc replacement, and the design decisions were made before we went on to the IDE study were validated. We have excellent results in the short term and the long term. And so the early disc replacements, I think, have set the stage for a paradigm shift in the management of degenerative disc disease in the lumbar and cervical spine. Thank you.
Great to see you, John. Thank you so much. So I really congratulate you on this research, and this is a visionary product. Obviously, the materials have remained very contentious. What happened? Why can I, as a clinician, not use the Maverick disc today?
It was never approved by the FDA in the United States because of an intellectual property dispute over the keel. Patine and Saleb had the keel patent, and that was owned by ProDisc. So it never was approved in this country, but it was a very popular disc in the rest of the world.
Jens, I'll make one other comment. We also did the Kineflex, which is a metal device. We came down to the FDA. We had excellent data, much like their data, and it was the time of the ASR metal hip that DePuy was getting sued, I think $1 billion for. And the FDA told us, don't come back because we're not approving any metal-on-metal devices for the human body. So that's the other reason it was never approved.
Yeah, that's what I was actually aiming for, because that material substance, as we now see with the long-term follow-ups from the polyethylene on metal, did not pan out really in the spine. I mean, the analogies are not appropriate. So yeah, it's sad.
The metal-on-metal.
One of the things,
Metal on metal did not pan out.
one of the things about that is a metal wear and corrosion and loss of the oxidative surface on a metal has to not only do with loading, but also the range of motion of the joint. So the forces in the hip and knee are so much greater, orders of magnitude more than the lumbar and cervical spine. And the range of motion is so much greater in, say, the hip. So that would create more problem for wear and corrosion. So that's why I'm pretty comfortable in the lumbar in spinal implants with metal on metal. And I was supposed to go in front of the FDA and the day before to support the metal on metal in that disc. They said, forget it, it's over. And it was almost it was a really disappointing thing for the Kineflex guys.
Todd, do you have a quick question for John?
Did anyone ever follow up on chromium levels or cobalt levels in the blood? Was that something that was screened for in those patients? Cobalt. Oh, so my question was as to whether or not there was any data around systemic release of cobalt or chromium ions in that.
There was. Yes, there was, and there wasn't really any significant ions.
We had written a paper on metal hypersensitivity. We had 2 patients in the Kineflex trial in which they got a giant cell reaction, and it was to the metal particles. We actually collected some data from Maverick, and there was several other metal discs that were throughout the world. We wrote a paper with Josh,
Jacobs?
Yeah, Josh Jacobs up in Chicago. And that was also one of the reasons why the FDA said, ixnay, no more metal devices.
Well, in the FDA trial, there was one explant of a Maverick, and it was infected with an epidural abscess. And, you know, I don't know if you're going to attribute that to ions or where, but it was more of an infection.
Tony Viscogliosi has a question.
John, first of all, congratulations on the good work that you did with the Maverick. It's a delight to be together here at this meeting. I'll comment just for the purpose of further disclosure that the Viscogliosi brothers acquired from Medtronic recently the Maverick disc and the Bryan disc, because we believe that there is great continued opportunity in the sphere of total disc replacement. And so although the Maverick did not make it through the FDA at that time, the world is different now. 15 years of data exist. So let's see where we can go with this.
Wow, you heard it here first.
Congrats on that, because I was talking to Jean-Charles, and he didn't get his 20-year data to me in time, but he said there was really no fall off. That the good results have been sustained at his 20 years. Now that's his one site, but I'm just really impressed with actually all the discs work really well. So the whole concept of motion is here to stay.
Thank you, John.
Absolutely.
Thank you, Tony. Our next speaker in the timeline is Izzy Lieberman. Izzy's been with us at TBI for a long time, but in his previous life, he spent a long time at Cleveland Clinic. And Izzy and Ed Benzel helped develop a disc that he's going to tell us a little bit about. Was it the Axiomed Freedom Disc then, or was there another name for it, Izzy?
No, it was the Axiomed Freedom Lumbar Disc.
Okay.
So
The podium
That's
is
where we're
yours.
going. It's a privilege to be invited to participate, to contribute, especially with what I affectionately refer to as my three amigos, who over the last 13 years have been giving me a lot of grief for the deformity work that I do. But I know that deep down inside, they know that I know that it is function, it is motion. That's the important thing over the years. So I'd like to share with you the story of Axiomed Spine Corporation and the Freedom Lumbar Disc. In the spirit of disclosures, I do have relationships with all these entities, and you'll see Axiomed is not up there because Axiomed is no longer in existence. But the inception was in the year 2000. This was in Cleveland, Ohio. And Chuck Burchell and Jim Curis approached Ed Benzel and myself on the heels of the Steffi disc replacement that was born in Cleveland by Art Steffi, and a number of them were implanted. Many may or may not recall that it was a rubber device, effectively, that was meant to absorb the shock, but had dismal failures. And Jim and Chuck approached us and said, we've got this other idea for this other polymer device. Let's start working on it. So we were then introduced to Ray Ross out of Manchester, England, and the three of us got together, and I learned an awful lot from those guys, both just exceptional thinkers about the biomechanics of the spine and the function of the disc. But the important thing was the spine kinematics. We all got hung up on motion, but it's more than just motion. It's the function of the spine. And the biomechanics were coming out and telling us that the spine kinematics, the disc kinematics, had two distinct phases. You had the neutral zone, where the disc is very compliant. So with low resistance and low load application, it moves around. And then you got that elastic zone where the disc becomes very, very stiff. And that's in response to high rates of load application or an accelerated rate of the application. Now, we all heard about the coupling, but the key thing is, what are the properties that we're trying to mimic, and why does the spine do this? And the discs work this way because of the viscoelastic design parameters in the end plate, the annulus, the nucleus. And that's what we set out to try to solve, to see if we could really mimic the spine kinematics with a disc replacement device. So we knew that the muscles are the actuators, that what moves the spine, and the restraints are the annulus, ligaments, and the nucleus. So the nucleus does not really provide motion, it's a modulator of motion. And those were the design criteria that we proceeded with on the study. And this is the stiffness curve of a natural disc. And you can see how the loads vary depending on the rate of load application and the timeline of that application. And it was a pure function of the hydrostatic and osmotic pressure, the tensile forces on the annulus, the compressive resistance forces of the end plate, and the load transfer characteristics of the end plate. So with that, the three of us came down and decided these were going to be our design philosophies. We want to restore the patient's normal functional spinal unit. Clearly, we want to enable or eliminate disabling pain and enable recovery and return to work. And obviously, avoid degenerative changes at the levels above and below. So we really focused on functioning, designing the disc to function like the natural disc. And we involved a number of individuals in terms of how we get it in, meeting the morphometric requirements of the spine. And then we got into the engineering challenge of designing a device that can withstand the lifetime of that patient. So we wanted a device that can last 40 or 50 years. So big goals, big challenges, and that's what we ended up embarking on. And this is how we designed the Freedom lumbar disc. It was a proprietary disc with viscoelastic polymer bonded to the titanium end plates, which provided the flexibility, the strength, and the shock absorption capabilities through the spine. Now, these are this is sort of the inside scoop of all of this. The polymer was a proprietary polymer that we had commissioned from one of the polymer manufacturing companies. We told them the properties that we wanted in it. The polymer had different biomechanical properties at room temperature versus within the human body. And we also had to bond the polymer to the titanium end plates to make sure that it wouldn't separate over time or with function, with movement. So those were our proprietary secrets, how we bonded it and what the polymer was actually made of. But our public information and the patents that we have was really the design, how we mimicked the viscoelastic properties. And if you look at the design, you can see there's a little cavity up here on these sort of end plate buttons that we have. And also at the edges here, the polymer was not bonded to the titanium at the edges. So what this allowed was, with compression, when the disc is loaded, the polymer could expand freely to fill up the gaps above and below, and to bulge out front and out back, sort of anteriorly and posteriorly. So at low loads, we could mimic the stiffness of the native spine. But at high loads, if any one of us were to stand up, jump up in the air, and land on our heels, at high loads, the disc became very, very stiff. The polymer wouldn't move. Once we had the design, we went through the various biomechanical exercises, and we saw that the Freedom lumbar disc had a similar stiffness profile to the patient's native disc. So the stiffness increases with increasing load. We'd achieved our first goal. Once we had that, we went into our preclinical testing, looking at all the different parameters, really flexing the disc, loading the disc to exceed that 40-year time frame that we wanted with the disc replacement. So as you can imagine, all of this took time, and we started in 2000, so this was some point in 2004 that we started going through the biocompatibility and biomechanical testing. And once we went through that, we initiated our pilot study in 2007. And it started at 2 sites in Europe with Ray Ross in Manchester and Frisching and Hollenbeck in Magdeburg in Germany, where we enrolled the first 43 patients. And the results were very, very promising with that group. The average improvement in ODI was about 48%. The VAS improved 66%. One X-ray demonstrated some device migration, but the metal interface was still there, so that was fine. And we saw that the motion was preserved at the adjacent levels, and we didn't have any serious adverse device-related events. So with that information, we proceeded on to unveiling it. And this was really the first public unveiling of it at the ISASS meeting in 2013, where Professor Rischke came and presented it. And at the same meeting, Rick Delamarter had a poster of the Freedom Disc versus the ProDisc, which was sort of the start of our FDA pivotal trial. But then in November of 2017, we filed for the pivotal trial with the FDA, and we went through that trial. Multiple centers. We had 13 different centers, of which Texas Back Institute was one, and this was preceding my arrival at Texas Back Institute. We enrolled over 400 patients. The numbers were good. But despite the clinical success, this was a business failure. And this speaks to some of the earlier talks that it's not just the science, it's not just the biomechanics, it's not just the regulatory, it's not just the reimbursement. You've got to have everything in line. And this is kind of a bittersweet talk for me because clearly I invested a lot of personal capital in designing the disc with Ray and with Ed, and we all went into a period of mourning when the company actually went into liquidation. And what happened was management just really didn't keep their eye on the ball at that point in time. And we were too far in debt. The banks called on our loans. The investors couldn't agree with each other as to who would cover the loans. And effectively, the banks gave us a deadline date and said by November 1, you guys, and this is up to 2016 at this point. By November 1, if you don't have the money in the bank, we're liquidating. And November 1 came and we were liquidated. So the technology's sitting with another company now. I don't know what they've done with it. I've kept away with it. But as you've heard this morning, motion is life, life is motion. I have no doubt that heavy metal is not the future of spine treatments. It's going to be appropriate intervention with some combination of a motion function preserving device or biologics. And we're going to get to that at some point, probably very, very soon. So with that, I thank you for the advice and thank you all for raising my anxiety back again with some great memories and bringing on my depression with some poor memories.
Great job, Izzy, and I'm glad that somebody is still a TBI left behind to watch the shop because we have the big other three here, but it's fantastic to have the big four here, at least in the virtual environment. So very cool of you and cool of your three partners to let them out of the house for today.
Thank you very much, Izzy. You know, it's the reality of life is things don't always go the way we want them to, and when it's out of your hands after you put in so much, I'm sure there's a lot of mixed emotion and angst to going back memory lane. But thank you for doing it for us. Going through our timeline, the last disc is the ActivL disc, and Jim Yue has had another commitment. He has pre-recorded the audio portion. He's going to try to coordinate it so that he could do it for some questions. I'm not sure that part's going to work out, but we at least have the audio portion. Are you guys ready to roll with that? So Jim's just going to talk about organization of the ActivL disc.
It started in roughly 2003. Approximately 5 surgeons were chosen to submit proposals for the next generation implant. We did not know the names of the other physicians. We were all flown over to Tuttlingen, Germany to present our experience and ideas and criteria for a new design in early 2003. Fortunately, Dr. Rolando Garcia and myself were chosen for this project. It was a rapid project. The first implant from conception to implantation was only 2 years. My own personal input really was born out of my work with Dr. Manohar Panjabi in his lab. I'd been working in his lab since approximately 2001, and we were always looking at forces on the spine, and he always used to say in the lab that shear was the enemy of the spine. And so from that point forward, I understood that the facets were being impinged on with the implants that we had been using already, and I tried to develop an implant that would control and unload the facet joints as much as possible. So we came up with a translational control translation concept, and you can see in this video, a 2-level video, in a patient post-operatively about 3 months post-op, how the implant actually works. It has minimal to no anterior translation of the superior end plate because of the core that slides from the anterior to posterior. And this unloading effect actually translates per segment pretty nicely, as you can see in this video. So we did only really 3 cadaver labs, one in April, one in June, and one in October of 2004. The other development team is listed here. We achieved CE mark, and then our first implant was in February 10th, 2010. This is the very first implant that was put in Rostock, Germany, successfully, without any issues. We then submitted our proposal and was accepted for our US IDE in 2007, and we were FDA approved in 2015. This was one of the longer IDE trials. This was a 3-disc trial, so we compared ProDisc, Charite, and ActivL, and so the FDA wanted further follow-up because of our unique study design. But overall, it's been a very positive experience, extremely enlightening. We've really gone far, I think, in our development and usage and understanding of the total disc replacement technology. And I'm sure in the future there's going to be other designs that will be better as we all learn more and more about the total disc replacement concept in the lumbar spine. So I hope everyone's enjoying their day and having a great course. Look forward to seeing everyone. Take care.
Yes, a question?
Questions?
Yes. This is going to be for Tony, because Jim said something very interesting at the end of his little short presentation, saying, I'm sure there'll be something better. Aside from you and your brothers, who else has the vision to put money into getting a new lumbar disc into the United States, the 100 million, 7 years, and all that? I see a bit of a barrier here, but after listening to your talk, I see maybe less of a barrier. What's your thoughts?
I think today there is less of a barrier. There's a fair amount of innovation underway in an oblique approach. There's an IDE clinical trial underway for a posterior disc. And there is further intellectual property innovation that we are tracking in lateral, oblique, and posterior disc intellectual property that's in development. Several of the same innovators, Dr. Buchner-Jans and others, are involved in new innovations. So the short answer is, I think the market for further innovation in lumbar total disc replacement is very substantial, the market opportunity, and I think it will be pursued by several
Let
companies.
me refine the question then. The question is, and I agree with everything you say, what about, we've proven that total disc replacement, lumbar, through an anterior retroperitoneal approach where you have the best access to the disc and have the best chance of clinical, maybe not clinical, but biomechanical success. Proven. What about, you said all the other different approaches, I get that. What about refining and making better lumbar discs for anterior, for a approach in a biomechanical milieu that's already successful? Can we make that better? And who's willing to spend the money to go to the next lumbar anterior artificial disc?
The Viscogliosi brothers are. I can speak to that, first of all. Secondly, I can say that I believe there is opportunity for PMA approval of adjacent to fusion, concurrent with fusion, and for 3-level. these are real opportunities, and these opportunities will expand the thinking and the understanding of what can take place in a anterior retroperitoneal approach. The issue that we need to deal with is that two physicians are involved, an access surgeon and a spine surgeon. And reimbursement has to increase for that to be dealt with more easily. But to come back, the short answer is we are interested in the expansion of that field, and we believe that there's an opportunity for discs that have demonstrated clinical success in IDE clinical trials but have not yet been approved could be acquired again and move through the FDA process for approval. So I think that's the next step that will happen.
But Tony, I think it's what you said before. It's that in the academic centers, the residents are not getting exposed.
That's the issue.
Until the surgeon base says, this is a great technology, regardless of the reimbursement, it's better for my patient, it's what I would want for my brother, sister, or mother. Until that philosophy changes, we're still going to have the problem. I gave a talk up in Boston where they are anti-artificial disc. I have a slide, and maybe you know better, but in 2022, there were 9,000 lumbar artificial disc implanted. 9,000 compared to over 100,000 or 300,000 spine fusions. Granted, a lot of them were for deformity, but nonetheless, the numbers are incredible. And until that mindset changes of the surgeon, it's tragic that the three of us are, we're big mahafs. We're the leaders. It's crazy.
So I would just like to comment there in one word, two words, totally agree. Please, the spine surgeon community needs to integrate total disc replacement, lumbar and cervical, in residency programs. That will facilitate the turning point.
Could not agree more. Let's have two questions. First of all, Dr. Ghazwan Hassan, and I want to recognize the international visitors, Dr. Mugisha from Dar es Salaam, Dr. Madeira. The list goes on, Dr. Sahid Taha. Thank you all for joining us from around the world. Very cool, and this is a historic venue here, and thank you for our industry supporters to make this happen. And this collaboration with industry and finance together with the surgeon community is huge. Ghazwan,
my
from
question
Baghdad.
to the inventors and the expert about when we reach this level of evidence with low complication rate and revision rates, as in you mentioned less than 1%, what make you to think in the near future whether to go to the last R or changing the design of these to get more better? Might be widening the indications of it. I'm talking about the cervical spine at least, because I think that's the data and the evidence and the number of the cases much more than the lumbar spine. So what's your in your brain right now comparing the near future? That's
Wants to take that. Expanding the indications, better biomaterials, where's the opportunity for improvement?
I think that the design we have is great. I think that the ProDisc has been around forever and ever. The ActivL, a similar design, a little more mobile. So I don't think it's a design problem. I think that, as Tony said, it's going to be in biologic. It's going to be for us to determine at what stage do we intervene. For example, if a person gets a herniated disc, not that every one of them will get symptomatic degenerative disease, but those that have further problems are among our best patients. When we do those patients that have previous discectomy surgery, they are wonderful. But the thing is, how are we going to treat them? Is it going to be some type of biologic that regenerates the disc? Is it going to be something that seals the annulus? I don't know, but I think we're into this regeneration, which is going to be the next phase. We're now treating, I think that the lumbar artificial disc is perfected. The technology we have, it's the same thing they have in total hips, and there can be variations of the theme.
I think, we are struggling to treat actually the black disc syndrome or axial neck pain or lumbar pain. Do you think that's applying the TDR or motion preserving in these, let's say, pathologies will improve the outcome of treatment of this, or still there is an option for a fusion in such cases? Because, you know, I think that's for disc prolapse, it's okay for cervical spine, but we face many cases with just axial neck pain, some sort it's called as non-specific back pain, or there is no clear definition just on MRI, it's a black disc. So do you think that's right now we can apply the TDR or motion preserving till we wait the result from the regenerative groups?
Yeah, we should do that almost next year. It's a huge topic, a great question. In the interest of time, and we have Dr. Rue online right now, he can probably address it, but Todd Allman from Stanford had a question, comment?
Oh, sorry, just sort of along those same lines. When I think about all the lumbar fusions I do a year, most of them really aren't appropriate for lumbar disc replacement. And I saw that the number of your lumbar disc replacements was a lot lower, actually, than I would have thought at your institution, because I bet the number of fusions that are done there is probably 10 times that. So when you think about, are we really trying to replace fusion here, or are we treating a subset of patients that are currently getting fusion and perhaps a big group of patients that are not getting surgery right now because we just don't have a good solution for them?
Again, great topic for next year, but I do think it's a subset of patients. It's the degenerative, not unstable, not deformity patients with symptomatic disease resistant to non-operative care. It is a small proportion that some surgeons elect not to treat. Axial back, for example, axial back pain and axial neck pain. But a lot of surgeons in the U.S. do treat it, and it's that subset that I think we're doing patients a disservice fusing them, and they should, you know, with the technology that we have, you know, at least see if there's not a contraindication, and, you know, frankly, you know the community, and make sure they've really exhausted non-operative care, because a lot of surgeons are real quick on the trigger to treat a black disc with a TLIF or something, which I probably not, you know, state of the art.
Jack, did you want to make a comment?
No, I'm happy.
Good. So